Audience. My name is Roger Levy. I'm a rheumatologist. I was born in Brazil. I went to medical school in Brazil. I trained rheumatology in New York at Hospital for Special Surgery at a time when lupus research was in early stages in the 80s, and we learned so much since then. And 6 years ago, early 2018, I joined GSK as a medical director in medical affairs. So I'm still working with lupus and other autoimmune diseases, and we are doing several research in the area, and I'm very excited to be part of this team at GSK. So lupus is a prototypic autoimmune disease. What does it mean? That something happens in the person's immune system that they start developing antibodies and autoimmune reactions to their own tissue. So this starts much earlier, before there is any clinical manifestation. After some time, 5, sometimes 10 years, that people already have what we call the autoantibodies, antibodies against self proteins, they may start developing manifestations, and there is a set of criteria that we can classify a person with a lupus disease. So with that, these antibodies that are developing against self tissue, they form immune complexes, deposit in the tissues, and it, like I said, the skin, the joints, the kidneys, the lungs. So they start to get inflamed, and the inflammation progresses. If they're not treated properly, this organ that is targeted will fail. So we have what we call the irreversible damage. We believe there are over 5 million people worldwide with the whole spectrum of lupus, some mild, some moderate, some more severe. Some people have chronically active disease, but most of the patients have waxing and waning, relapses that we call flares, and periods where they're doing better. It's very variable. Not all patients have the same clinical manifestations. The most common sites that are involved, again, with different types of manifestations, are the skin, the joints, the hematological with anemia, thrombocytopenia, low platelets, and the autoimmune reactions that we have data to support that they are the triggers of what we see in the clinical picture. Most of the patients are relapsing and remitting. They have good and bad weeks or days. Sometimes they feel like, I'm healthy, I have nothing. Sometimes they feel like they can even get out of bed because they're the constitutional symptoms too, like fatigue, cognitive impairment, like we call it the foggy brain. You can't concentrate, hard to focus. Some are very hard to specify how this is happening, but it's very common to see those findings. Like, we know there is a criteria to classify lupus that is proposed by the American and the European rheumatology societies. We have an autoantibody test that is a prerequisite to enter the classification criteria. It's called the anti-nuclear antibody. So positive anti-nuclear antibody doesn't mean you have lupus. It means there is a chance. And then we go one by one organ systems, and then you score. And if the score is more than 10, this person is classified as having lupus. It doesn't have to involve the renal, the kidney disease in all patients. Actually, some people never have kidney disease. We believe it's about 60% of lupus patients that will develop the lupus nephritis at some point, most likely in the first 5 years after they're diagnosed. So 80% or more develop nephritis, the renal glomerular inflammation, within the first 5 years. Some patients have the lupus nephritis as the first manifestation. And this is not so easy to diagnose when it's the first manifestation, because you're not aware that that person is already has lupus. So it may take longer for those. It may take longer if they are in the pediatric or teenager patient, because they think of other causes. And it's very important to diagnose it the sooner the better. And we can only confirm the type because there are different types of histologic involvement, and you need the kidney biopsy. You need the tissue to look under the microscope and know what type of inflammation there is there. If it's more active, if it's already late stage chronic, we may decide not to treat so much. So biopsy is the gold standard. One of the difficulties in diagnosing nephritis fast is that there are not too many clinical manifestations. It's good and bad, because it's good that the patient doesn't feel much, but it's bad that it doesn't call the patient or the healthcare provider attention that there's something wrong. You may find only protein in the urine, which means you need the lab test, a dipstick to look at protein. Or the patient may look and say, oh, my urine is darker, there's blood, it's like tea, it's foamy. The foam in the urine means there is protein in the urine. But those are non-specific, and only people that pay attention would know. So when there are clinical manifestations, in addition to the urine characteristics that I mentioned, patients can have edema. The legs can be swollen. Sometimes when they wake up, the eyes are puffy, so edema, retention of liquid. You can have hypertension, high blood pressure, okay? And only when the disease is progressing and you don't treat it properly, you have other characteristics of more edema, headache, and other things. Once you know, I'm in front of a lupus patient and I want to follow this person with a plan. We call it the 3 to target plan. You come here every 3, 2 or 4 months, and I'm going to check your blood for labs, for those antibodies we mentioned. Some are related to disease activity. I'm going to order urine test every time I see this patient. So if there's anything that's outside of the normal range there, you can start opening your eyes and say, oh, I'm not going to see you again in 3 months. I want to see your urine again next month. Or I want to check your blood pressure every week, see what's happening. You get a red light blinking there that you need to approach this patient closer to make sure you're not missing this diagnostic opportunity at an earlier stage. Because of course, like most of the other diseases, the sooner you start treating, the better outcome you have. So in the past, and I'm talking about 1950s, 60s, it was prednisone, cortisone, more and more and more, and it helped save lives in the short term. But then I don't have to tell you about all the list of side effects that high-dose prednisone for a long time can cause. In the 70s and 80s, we learned from the oncology colleagues to use immune suppressors, not as the same high dose as they use in treating cancer, but for longer duration with a lower dose, immune suppressors that will help us have a greater effect of the control of the inflammation and try to use less steroids. It was good, better than steroids alone, but still with those treatment schemes, we were having, with the type class 4 of lupus nephritis, 40–50% going on dialysis and needing a transplant in 10–15 years. The treatment has immune suppression, unselective, so they are getting more infections, risk of bone marrow toxicity. And one of those treatments also can cause ovarian failure. And like I said before, most of the lupus patients are young women. Then other immune suppressors came in the market. Also, they are used for prevention of transplant rejection and to treat some types of oncologic diseases. And some are IV, some are oral. Then we learned that there is a initial phase of treatment where we are more aggressive in the immune suppression, and then we lower the inflammation, and then there's a long-term maintenance treatment that should last at least 3 years. Some people go up to 5 years, and all this time you are monitoring the patient closely, making sure the treatment is going as planned. So you want to decrease the amount of protein they are losing in the urine. And at the same time, you want to preserve the kidney function. That means you want the glomerular filtration rate to be as it was before the flare, or at least maintain 10, 20% from that level. So we measure the creatinine in the blood, and we don't want that to be increasing so much that will mean to us that the patient is losing tissue in the kidneys, and that's irreversible. So ultimate goal of the treatment is to avoid that, what we call the end-stage kidney disease. So the treatment today is important to be started as soon as we diagnose, and specific, individualized for each patient, to control the disease activity first, but also to prevent new flares. Because so in 2020, a product from GSK called belimumab or Benlysta was, we published a paper on New England Journal with a study that involved more than 400 patients with lupus nephritis. And when we published that paper, it was demonstrated that adding Benlysta in the beginning of the treatment, in that initial phase, on top of the standard therapy, had better results than the standard therapy with immunosuppressors and steroids alone. Meaning, we had more patients that went into complete renal remission. We had less patients on the Benlysta arm going into relapses, new flares, and ultimate goal was also demonstrated. The number of patients in the Benlysta group of the study that preserved the kidney function was higher than those patients in the control arm. So this was enough to show FDA and other agencies all over the world the benefit of adding this type of treatment that didn't increase any safety signal. Earlier, I mean, mid last year, we had the EULAR, the European League Against Rheumatology, releasing their guidelines for lupus in general, but they also mentioned lupus nephritis, suggesting the use of Benlysta early in the treatment and also maintaining throughout that maintenance phase. And more recently, just beginning of this year, 24, we had the group of renal experts, the global experts in renal disease called KDIGO. They're Kidney Disease Global Outcome Group, and they gather every 3-4 years to review the evidence of the literature. And with that, they released clinical practice guidelines where they recommend the best forms of treatments for each type of patients. So for patients that had biopsy with a class 3 or 4, there are the types that are more at risk for developing end-stage kidney disease, the more inflammatory types. They updated these recommendations based on the evidence, and they recommend the use of belimumab early in the treatment algorithm, right up front. So we believe at GSK that people with lupus don't have to suffer those consequences anymore. We can avoid the dreadful organ damage that we know once it starts to develop, the risk of accruing further damage is increased, and early mortality. So we want our lupus patients and people living with lupus to live longer, but also with a better quality of life. And this is all based on evidence with studies that had a large number of patients and a longer duration. And now we are also gathering data from real life experience, observational studies, open label, but like we say, real life. And we are hoping that we can work with the medical, academic, and the patient community to really modify the course of this disease and help people avoid those unnecessary burdens in their quality of life and also in the cost for the system.